Dear colleagues, welcome to a new exciting dialogue. You know that our Socratic dialogues are very interactive, and we love to involve you in our conversation. Conversation are typically very interactive and exciting with top cardiologists in the world, dealing with important topics for cardiovascular medicine. And today we have, as usual, a very important guest. He's a very young guest, but he's already a top cardiologist in the world and is conducting very innovative studies. The title of this conversation is An Innovative Look to Artificial Intelligence with a Protagonist. And the protagonist is Charalambos Antoniades. He is our guest today, and I'm hosting Charalambos with Chiara Bucciarelli-Ducci, who is the Deputy for Imaging in the editorial board of European Journal. Again, will be a very exciting dialogue. Be ready, no slides, interaction, but we will learn a lot today from Charalambos, not only his science, but also his human side. Charalambos is a very good friend of mine, and I always enjoy not only his science, but also his humanity, his passion, which is contagious. And we are ready now to listen to him. Chiara, please, can you introduce Charalambos?
Yes, with pleasure. So hello, everyone. Thank you for joining us. And thank you, Filippo, for the invite to share this dialogue with you. So as you heard from Filippo, we have a super guest today. So Dr. Professor Charalambos Antoniades, Harris for France, is a professor at the British Heart Foundation Chair in Cardiovascular Medicine at Oxford University. And he works as a consultant cardiologist at the Oxford University Hospitals. He was awarded his PhD with the honors back in Greece, where he's from, at the University of Athens, on a study on genetics of premature myocardial infarction. And during his PhD, he won multiple important prizes, notably the Young Investigator Award competition of the ESC, in fact, not once, but twice. And also the American College of Cardiology, and also the HR Society. It was awarded Outstanding Achievement Award for Cardiovascular Science Council, the European Society of Cardiology in 2016, a National Clinical Excellence Award in 21 in the UK, and also a National Clinical Impact Award, the highest entry in more recently in 24. He's been recently, as of a few weeks ago, in fact, elected Fellow of the Academy of Medical Sciences. So much congratulations, Harris, for this major milestone, really. And what's very interesting about his research that he really focuses the crosstalk between adipose tissues and the cardiovascular system, as we're going to hear today, and particularly using non-invasive imaging to image inflammation of the coronary arteries, pericoronary arteries, and using AI. And he's been coordinating multiple international studies, notably the Orphan study, which is also related to his area of research. Essentially, what has been investigated extensively over the last few years is the use of novel AI-derived imaging biomarkers of peri-inflammatory fat, inflammation of the peri-fat of the coronaries using computed tomography, and the important role of these novel imaging biomarkers as a cardiovascular risk prognostic factor. And also interesting, I've learned recently that he hosts the world's first hybrid interventional cath lab with a photon counting CT. And so basically those two rooms are connected and patients can be wheeled quickly from one to the other machines. And so that allows a lot of pathophysiological studies in the acute phase, which hopefully we're going to hear about today. And finally, he's the Deputy Editor of Cardiovascular Research, which is obviously a major journal, and he's published more than 400 papers, and notably in journals like The Lancet, Circulation, JACC, European Journal of Course. And finally, he's the founder and chief scientific officer of an Oxford University spin-out company called Carissa Diagnostics, which has basically commercializing this new imaging biomarker as a risk factor and to manage patients with coronary artery disease.
Chiara, you are mute. I cannot hear.
Problem with the sound.
Appears to be something with Chiara's sound.
Chiara.
Oh.
Yeah,
there we go. Now we hear you again.
Action.
Okay, I don't know. It's outside my control because I didn't mute. Apologies for that.
This is live stream, and when something's live, everything can happen.
Yes.
Please.
All right. So I hope you heard my introduction because I think it was
absolutely.
Just most of it.
The last few seconds.
Okay, excellent. So it's very impressive, Harris, what you have achieved in your career and all the major milestones. And we're really eager to learn more from you. And so I'll start with the first questions that we have on store for you. So let's start with the personal question. Your scientific career started in Greece. And can you tell us a little bit more about your mentors in Greece and why did you end up moving to the UK?
So thank you, first of all, Chiara, for the introduction, the very warm words. Thank you, Filippo, for the invitation to participate in the dialogues. It's a great pleasure, great honor, knowing who else has attended, has presented in these dialogues. It's a really great honor for me. You said I'm young, but this is in brackets because I'm not that young anymore.
You look young. That's the most important.
Yeah, that's
what matters is the epigenetic age, and your epigenetic age is remarkably young.
Okay, good. So coming to your question, Chiara, as you mentioned, I studied medicine in Athens Medical School. As an undergraduate student, I started research, which was essentially in brain biology. If you look into my first papers back then, they were all about sodium, potassium, ATPases in the brain, ion channels in the brain. So it had nothing to do with cardiology. That allowed me to get my hands onto tissue from animals. It was all basic science done in the physiology department there. When I graduated, I went on to start a PhD in parallel with my clinical training in Dimitris Toussoulis' lab. Filippo knows Dimitris very well. And that was quite an experience. For those who know Dimitris, he's a very impressive guy. He sets expectations that he knows that you'll deliver probably 10% of this, but then he pushes you to deliver as much as possible. So that was quite an experience because it taught me to be resilient, and it shaped essentially my persistence in delivering science. Then by the end of the PhD, I thought I should come to the UK to study a little bit basic science with Keith Channon. Back then, Keith Channon was a professor of cardiovascular medicine in Oxford, a young professor. He was doing a lot of research on gene therapy and on the role of endothelial nitroxide synthase in cardiovascular biology. I came for 6 months. That was the agreement. When I was discussing with Keith back then, that was in 2004. When I was discussing with Keith, he was trying to convince me to stay for a year. And I pushed back and I said, well, I have a family in Greece. I cannot come for a whole year. Maybe I will make it 8 months. So now it's 22 years, 21 years, and I'm still here. So this is essentially how life changes your plans unexpectedly. But of course, there are no regrets. I came to Oxford, and because of the very good mentors I had from Athens and also with Keith Shannon here in Oxford, I feel very lucky because I built a career with a lot of support and care from my supervisors.
Chiara, before you come to your next question, just a personal note. Charalambos, you're right. Your Greek mentor, Dimitri Tousoulis, is a great friend of mine. We met many years ago. And coming back to the age, we have the same age, more or less. This means that either you are very young or I'm very old. I'd like to go for the first hypothesis.
Of course, Filippo, it is the case. So, Hadis, many of your initial publications were on mechanisms and translational cardiology. What attracted you, your interest in this field?
Yeah, so for me, research has always been about discovering something new. And to give you some information which is not widely known, medicine was never my first choice. I wanted to study astrophysics. And I did have an offer from a very prestigious university in the UK to study astrophysics. But because I was from a non-wealthy family, financially, it was not viable. That's why I went to Greece, where there were no fees, tuition fees, and I studied medicine there. And the compromise back then was that I will no longer focus on studying the universe, but I will focus on studying the human body, which is not much different. Actually, it was proven to be much more interesting, studying the human body than the universe. And why basic science? I started from basic science because that's more exciting. You get results by the end of every experiment, and you see the results. In basic science, you build the one experiment on top of the other, and you adapt, you change, and this keeps you the excitement. Unlike clinical research, where you have to work very hard for a very long period of time, collecting data, and then you have a brief period of intense, exciting data analysis, which will lead to the discovery of the result. In basic science, the excitement lasts all the time. It doesn't come in waves. And that's why I started from basic science. Now, I focused a lot at the beginning on vascular biology, especially when I came to Oxford. I studied a lot endothelial nitric oxide synthase. It was back then, 2004, 2005, when endothelial nitric oxide synthase was proven to have a bad phase, a nice phase, and a good phase. It becomes a source of free radicals or a source of nitric oxide, depending on its coupling status. That was a very exciting field back then. That allowed me to build a very strong research program together with Keith Shannon as a fellow around inos biology, redox state, NADPH oxidases in the human vessels, in the human myocardium. So that was the exciting field that I started my research from. It's not that I find clinical research boring, because at the end I ended up focusing exclusively now on clinical research. But it's all about the journey. It's a transition from basic science to clinical.
Yeah, and it's really inspiring to hear your stories, and I'm sure some of the colleagues that connected, they'd be inspired to hear, the journey that you described. So how did you turn your interest then on ischemic heart disease? Why and how?
Yes, again, it wasn't that I turned my interest. It's more about evolution, because I started from studying the cells, the biology of the endothelial cells and of the vascular cells. And then that evolved into studying organs. I started running all these experiments that were focusing on ex vivo models of human vessels collected during cardiac surgery, mammary arteries, veins. pieces of the myocardium kept alive outside of the human body and doing all these experiments. And then this gradually evolved into studying the organs and the whole organism. And that's how it evolved into studying ischemic heart disease, because that's the end game of atherosclerosis. So it's a continuum. It's not that I shifted towards ischemic heart disease. That's part of the same concept. It's just a different way to approach it.
Yeah, fascinating. And what would you consider your main contribution in the field of ischemic heart disease, at least to date?
Yeah, so probably if I take my most highly cited papers, if that is a metrics of acceptance of research, Filippo knows what I'm talking about as editor of a journal. If that is an acceptable metric, I think the work I have done 20 years ago on redox state, on enos coupling, was quite important work, very highly cited. Also, the first papers that demonstrated the pleiotropic effect of statins on human vessels, it was probably one of the most important contributions that I have made to the field. It was back then when I used to keep these human arteries collected during cardiac surgery alive outside of the human body, exposing them to statins in the absence of LDL, and studying their response, the response of human arteries and human myocardium, again, myocardial samples kept alive. And that was how we discovered that statins have direct effects, anti-inflammatory effects on the human vascular wall and on the human myocardium. And they modify free radicals production, redox state. And that essentially set the basis for the anti-inflammatory mechanisms of disease modification by statins. And of course, in the more recent years, most of my research was focused on the interactions between adipose tissue and the cardiovascular system, the mechanisms by which obesity affects the cardiovascular system, and again, all these studies that we have published related with the secretome of the human epicardial fat on the human coronary arteries and on the myocardium are also, I believe, important contributions to the field. Of course, compared to the contributions of Filippo or you or others, is probably, fine prints, but for this particular field, I think they are quite important.
Fascinating. Thank you so much. And we want to encourage the audience to post questions in the chat that Filippo and I will ask Haris throughout this dialogue.
Well, if there are no questions, we can continue our dialogue waiting for questions from the audience. Chiara, if I can, I'd like to ask some questions also to Charis. Now, first, let me comment on your curiosity. This is an important driver. You started with astrophysics, and then you moved to basic science, tissue and cells. And then you thought, okay, but let's see what happens when we put cells together. And then you started your journey around the human body and within the human body. And curiosity has been the driver. And I always tell my younger colleagues that when there's a brilliant mind is flooded by questions, but many questions, but not all questions are relevant. So the real challenge is to identify among the many questions what are really important and impacting. And you've been extremely successful because not only you addressed several questions, you asked yourself several questions, but also you managed to identify the relevant questions. And this is why your contribution to the history of cardiovascular medicine is so important. Now, I have one first and then a second question. Let's stick for a while to ischemic heart disease. What has been your major contribution to ischemic heart disease? What is your favorite baby where you say, okay, here I made a difference? I know it's not an easy choice because we have done so many things, but what is your favorite baby in this field?
So I would say it comes from the more recent research that I have done that has to do with the crosstalk, the interaction between the cardiovascular system and the adipose tissue, particularly the role of epicardial fat in the regulation of cardiovascular redox signaling. For many, many years, we have been discussing about obesity being a risk factor, but in reality, we were never able to understand why and what connects adipose tissue with the cardiovascular system. So all this concept of adipose tissue secreton, what is secreted by the adipose tissue that could be either protective or detrimental on the human heart and on the human coronary arteries. This is probably my favorite contribution, particularly the work that we have published on the crosstalk, the bidirectional signaling that allows a communication of the adipose tissue with the human heart, where the fat secretes molecules that are affecting myocardial and vascular biology, and then senses signals from the myocardium and from the coronary arteries in order to adapt. This bidirectional signal that originally was published in Circulation, then we published, that's back in 2013. Then we expanded this concept in the interaction between the myocardium and epicardial fat. That was a Circulation research paper, and then a Science Translational Medicine paper followed on to further elucidate the mechanisms by which fat affects the cardiovascular system. I think that's probably my baby, as you say, in terms of contribution to the field.
Well, and this baby is growing quickly. And in this growth, I think that an important step has been the introduction of artificial intelligence in the interrogation of perivascular fat. So this is in your interesting scientific history has been something which happened more recently, your interest for artificial intelligence. And again, the question is what triggered your curiosity for artificial intelligence? Was the study of perivascular fat the trigger or something else?
Yeah, I would say it was a passion for discovery, because when you perform research, you always hit a ceiling. So there is certain things you can explore and certain things you cannot. And when I realized what opportunities we have by using AI tools in bringing to the surface hidden information from images, analyzing large complex data sets, like multi-omic datasets, large proteomic datasets, large transcriptomic datasets, and integrate everything together in order to better understand the biology of the tissue you are interested in, then that's what really excited me originally to get into the field of artificial intelligence. It started by the need, first it was a need to analyze images from large imaging datasets that we were not able to analyze by using our eyes, our human eyes. And then we brought this hidden information to the surface by applying artificial intelligence models. Another very important aspect of that was the driver behind getting into the field of AI was the ability to accelerate tasks that we have been doing in the lab. For example, you want to segment images. to segment a complex structure, it will take you a few hours. Let's say that you want to segment the coronary arteries and the epicardial fat with the pericardium. To segment this manually, it would take you an hour, sometimes more. By applying AI models, I realized very early on that that could accelerate research dramatically and will allow us to analyze these, segment these images within seconds. And automatically, from hitting the roof in terms of analyzing big data sets that used to take months, weeks, years, whole PhD projects, this can now be done within an hour, within a few minutes. The time that a whole PhD project used to take is now taken up by a few minutes of computational time of an AI model. So this was a big revolution that you just, follow the tide, take advantage of what tools are available, interact with engineers, interact with people who can support a medical group to get into the field of AI, and then you see miracles.
Sticking to artificial intelligence, they're not necessarily related to your studies. But what do you think is what do you see in your crystal ball? What will be the initial clinical applications of artificial intelligence? Because there's a lot of discussion, many studies, some of really very high qualities, not all of them, but some really excellent, like your studies. But what do you think will be the first entry of artificial intelligence in daily clinical practice? Will be better diagnosis, better relation with the patient, better risk stratification, or what? What is the sequence of AI in our daily practice?
Yeah, I would say start by looking how AI is in daily practice today, because we may not realize it, but in reality, AI is everywhere. Every time you sit in front of your echo machine and you try to calculate the ejection fraction, you have noticed that now this is calculated automatically, right? All the vendors, they have these AI tools that give you the metrics that you used to spend a lot of time to get manually a few years ago or eyeball them. So this is already in practice. Every time you perform an ECG to a patient, on the corner, you see a diagnosis. It's not always right, but probably you have realized that as time goes by, it's getting better and better. So that's an AI model. So this is in clinical practice today. When you do wards to see patients with the juniors, I'm sure that we have all experienced the junior who come with a phone and be extremely well in picking up the diagnosis of the patient that we have in front of us. And then you realize that the junior is reading ChatGPT because that is actually giving you very good diagnosis and very good differential diagnosis. So this is happening. It's in our hands today. Every time a patient calls a hospital to book an appointment, in many hospitals, at least in the UK, it's very common, the prioritization to happen by using an AI tool. Every time you open your PACS system to analyze any kind of images, medical images, there is an element of AI to pre-process the images that you are already looking at. The technology that we have developed, the CAIHA technology that measures inflammation in the coronary arteries and predicts risk, is in clinical practice. So this is an AI model that gets CT scans and tells you what's your possibility to have a fatal cardiac event over the next 10 years. And then we see that it changes already the management in 45% of the patients in the NHS where it's being implemented. So this is today, it's not in the future. This is AI applications today. Now, if you're asking me what is the future, I would say the future is not that far. The future is probably, we'll see big changes in the next year or two maximum. We will see AI battling to replace clinicians, to replace technicians, to replace even taxi drivers. I was in San Francisco a couple of months ago. I got into a taxi that a friend of mine called to only realize that there was no driver next to me. And the taxi took me through the city to the other side of the city. And I was holding on the chair like that because I didn't know what's going on. So that is happening now. This will change the way also we practice medicine. And we have to adapt, and we have to be able to take advantage of it, but without compromising the quality of care we give the patients. So there are many changes coming. Let's wait and see.
Yeah, but let's elaborate on your comparison regarding cars with the autopilot. If the car is the patient, the pilot is AI and we are co-pilot, or we are co-pilot as doctors and AI pilots and the AI is co-pilot, or there's no need for a co-pilot?
At the moment, I would say what is a formal view of the regulators. The regulators at the moment, they say that any AI tool needs to be used or can be used as an aid to the clinician, as an aid for diagnosis. And the responsibility is always with the clinician. There's always a human in the loop. This is standard approach of the FDA, of the European agencies, etc., and in the UK. However, this, I believe, that's my personal view, this will change, and it will change dramatically in the next few years when we start to realize that actually, if there is an error, that usually comes from the human in the loop, not from the machine in the loop. And we have already started seeing this. So we have big projects in Oxford where we analyze big data sets and we compare the human with the machine in terms of analyzing and interpreting CT scans specifically. And we do have some variability, some disagreements, but when we look into these agreements, usually the machine is right. And usually the human operator just got tired at some point and started doing mistakes. And that's something that will never happen with the machines, because the machines learn from their mistakes, but they also learn from the mistakes of all other machines in a network in the world. And then they never go back, while humans learn, but then they forget and they don't pass on their knowledge to others. So these are big questions that we don't have the answers. Now, pilots or co-pilots, I believe that at some point, maybe in the future, will be paid to just stay out of the way.
And what about empathy? Better AI or better human beings?
Yep. So I was in a talk that Tom Lucier gave recently in the European Thoracic Society meeting, gave one of the plenary sessions. And I was not aware of that, but he was referred to a study in which they compared the patient's experience when they interacted with a human in a clinic versus an avatar. And actually, they rated the avatar as more compassionate and at a higher rate in terms of empathy compared to the human doctor. Because all these are things that can be copied, can be cloned, and can be mimicked. So it's scary. It's really scary. But we have to keep our eyes open because this is coming.
Yeah, I was in the same room listening to Tom Lucier, but I was so shocked that I prepared to ask you to be sure that I well understood. But looks like that I well understood. Chiara, enjoyable conversation. Back to you.
Yeah, very much. Maybe the physician was not a female physician. That's why the empathy. Who knows? Who knows? That's another topic, I guess.
And of
But
course, yeah, we have other issues that we need to keep in mind. Sorry for interrupting, Chiara, because it's not only the empathy and the interaction of the patient with the machine. There are other risks. So it's de-skilling the clinicians, because if we all rely on automated processes happening by the AI, then if there's a power cut, we'll have a problem.
yes,
Because we cannot practice medicine. We cannot calculate the ejection fraction. We cannot think. The juniors rely a lot now on these GPTs, the models, and then when they don't have the phone with them, essentially they cannot make a differential diagnosis. And then, of course, we have the loss of jobs, which is another issue that may come. It is happening now, right? All these are things that we need to think them through and solve them in order to start working with the AI and integrate all these systems into our daily practice.
yeah, which is why the co-pilot, I think, concept is actually very important, because it will take care of, I guess, both aspects, increase the robustness of what we do, but equally without the risk of de-skilling. But yeah, more to come, because I think as we train the new generation of doctors, I mean, we're faced with those challenges every day, right? So here we go. So I like to learn more about the story of this perivascular adipose tissue and imaging, AI, how this is all started, was just an observation you made, and then you start investigating the mechanism, giving your basic science, I guess, mechanistic kind of mindset. And why did you choose to use CT also?
Yeah, that's a very big question. So everything started, I would say, back in 2010, when I was awarded my first intermediate fellowship by the British Heart Foundation. And the focus of the fellowship was on studying how perivascular fat affects vascular inflammation and vascular disease. And we're running all those experiments where we were collecting human mammary arteries with their fat. We were separating them. We were using the human mammary arteries to measure inflammation and oxidative stress. And then we were quantifying the production from the perivascular fat of protective molecules like adiponectin. And the whole fellowship was trying to prove that when you have a lot of adiponectin in the perivascular fat, that will be secreted, it will go to the vessel, suppress inflammation, suppress oxidative stress, and then you will see low oxidative stress in the vessel. So you are expecting to see an inverse association between the two. I had a very brilliant PhD student, DPhil student back then, who started these experiments. He spent the first 2 years of his DPhil collecting all this data. He collected around 100 biopsies from patients during cardiac surgery, ran the experiments, and he came to me, and the result was the opposite. Essentially, high adiponectin in the fat, in the perivascular fat, was related with very high oxidative stress in the vessel. And he came to me and said, the results are the opposite. What can I do? So at that point, I dismissed it, because I didn't want to accept that my whole hypothesis, my whole fellowship, the whole program was wrong. That I was chasing the exactly wrong hypothesis. And I sent him back and I said, do it also in veins and do it more times. I was hoping that if he does the experiment more times, he will get the result I wanted to see, right? That was the mindset of the inexperienced PI. The poor guy, he did the experiment 601 times.
Wow.
And then he came back with 601 patients with mammary arteries and veins, showing that high adiponectin perivascular fat is related with high oxidative stress in the vessels. And at that point, I was thinking of giving up, because this doesn't make sense. We expose vessels to adiponectin and they suppress oxidative stress. But then when you look into them in the human body, it's exact opposite. So what's going on? And that was a point when we realized that actually we may be reading the book the wrong way around. And it's probably, we thought, it's the vessel that is under attack by oxidative stress and inflammation, and somehow it sends a signal, an SOS distress signal, to the neighbor, which is the perivascular fat. The adipocytes somehow sense this signal, modify their profile, and they become secretory cells to send more adiponectin back to the vessel to suppress inflammation. And that's how the whole field started. And then we realized that actually the fat responds to signals from the vessel. And during this process, when the vessels are inflamed, the fat cells get small because they get rid of their intracellular lipids. They become secretory cells because they're going to produce more proteins to come and help the vessel. It's a compensatory mechanism. But during this process, the perivascular fat loses its fat. And then you get what we see as lipolysis around inflamed structures, which is very known from the field of cancer. If somebody has cancer, they lose weight, they lose fat, they have cachexia. And this is driven by cahectin, which is tumor necrosis factor alpha. Exactly the same concept happens in the microenvironment of the vessel.
Sorry, we have lost your voice. We have lost
Yes.
it in the last few seconds. I don't know what's happening.
Can you hear me now?
Oh, yeah, you're back.
Now it's perfect. I don't know what happened, but now it's perfect.
Okay.
Just a few seconds.
Yeah. Okay. So I was saying that the whole concept was that when you have an inflamed artery, that artery secretes now molecules in the perivascular space, activates lipolysis, and then you have a change of the composition of the perivascular fat in favor of the aqueous phase. Now, when we discovered this basic biology, we thought, okay, that's interesting, that's exciting, but can I get a biopsy from the perivascular fat, every artery, in order to tell if the artery is inflamed? That's not possible, because all this was done on biopsies from patients, thousands of biopsies. And at that point, we thought, maybe if we use MRI, we can visualize these changes around the coronary arteries, and maybe we can see this shift of the composition of the fat around the arteries. We tried with MRI. We spent a very long time with Stefan Neubauer, who Chiara and you, Filippo, know very well, trying to figure out how can we visualize these changes in the perivascular space with MRI. But the voxel was so big of the MRI that we couldn't capture these changes in imaging. Before I give up, I thought, okay, let's try CT, which has better spatial resolution. Maybe we can pick these signals around the vessels. And then we started going layer by layer manually with my fellows in Oxford, trying to see if you move 1 millimeter at a time or 0.5 millimeter or less at a time around the vessel, can you see changes that can correspond to what you see in the histology? And that's how we developed the method with the fat attenuation index that maps the perivascular space on routine CT angiography and tells you whether you have these changes, the characteristic changes in the perivascular space, which are not indicating a disease of the fat, but they are telling you whether the vessel which is attached on the fat is inflamed. And then we developed the method to make sure that this is specific for the vessels and became a clinical product. And essentially now it's in clinical practice around the world.
Yeah, fascinating. Well, in fact, there are two questions from the audience. Finally questions are coming up. So one colleague is asking, so is there a multimodality approach to what you're describing? So you alluded to the CMR was your initial idea, but technically maybe a bit challenging.
Yeah, so in terms of imaging modalities, essentially you have CT, you have echo. Echo doesn't give you a proper visualization of the coronary artery, so that was not possible. Then you have PET. PET CT was indeed one of the methods that we tried to use, but that was not practical, because when you try to use radio traces for the coronary arteries, if you use FDG, then there is so much noise from the myocardium that you lose the signal. Sodium fluoride was not sensitive enough. It was very specific when you have an acute event, and you see that when you quantify the fat attenuation index with CT and you correlate it with sodium fluoride PET uptake of ACS lesions, you get a correlation coefficient of 0.7, which means that there's a very strong correlation between the two. But the installed basis of PET is not great, so it's not readily available, so you cannot easily scale up. And in order to build prognostic models by using this kind of technologies, you need to be able to scale up and perform this analysis in thousands of patients. And that's why CT was essentially the only viable solution for this.
Yeah, for the spatial resolution. So another question in the audience is, how is AI being incorporated into the PHI index that you alluded to?
Yeah, so AI is in every step. First of all, the segmentation. Segmentation is an extremely challenging concept, because to segment these the coronary arteries and the perivascular space, you need to take into account the complexity of the anatomy. It's easy when you do it on the right coronary artery, proximal segment, because it's just a pipe. When you get into the other areas, you need to apply an AI approach, because in that way you handle the anatomy better. Then you have essentially the quantification of the gradient of attenuation needs to be done in a multidimensional way. And there is a lot of AI involvement in putting together this kind of metrics. And now we are moving towards a radiomic approach to make it even more specific for the specific type of inflammation you want to capture. And with the radiomic approach, or the radiotranscriptomic approach, where we use as ground truth transcriptomic information, and then we train the radiomic models of perivascular fat against a transcriptomic ground truth, this is really a revolutionary approach that there will be big papers coming out soon looking into this radiotranscriptomic approach and how it can even further improve the prognostic value of these metrics.
Excellent. So much is going to change, I guess, in the field that, how we treat patients and diagnose patients. So can you summarize then your main innovations and discoveries, in fact, through using CT as an imaging modality to image the perivascular fat, inflammation of the perivascular fat, and how do you think this is going to be a therapeutic target?
Yeah. So these are two different things. So essentially, with the fat attenuation index, this phenotyping of the perivascular fat, you detect vascular inflammation. And with the more advanced analytics, the radiotranscriptomic approach, you can identify the type of inflammation that is driving coronary disease in the individual patient. This sets essentially a therapeutic target inside the vessel by using perivascular fat as a sensor, as a window to identify this inflammation from inside the vessel. There is a large number of clinical trials now that are using different biologics in addition to statins, because the first trials used statin treatment, showing that when you treat patients with statins, you see suppression of inflammation measured by using this method. Now there are biologics that target specific types of inflammation in the vascular wall, and the treatment is now guided by inflammation measured using this method. Then it's the targeting of perivascular fat itself as a therapeutic target. And that's a different area of research and it's not related with imaging, because you can still target perivascular fat, modifying its secretome towards a vessel-friendly profile. So you could potentially target perivascular fat to increase the production of IL-10, of adiponectin, of the secretion of hydrogen sulfide that would then prevent disease, vascular disease, and atherosclerosis. Or you can suppress the production of detrimental cytokines like IL-6, like TNF-alpha from the perivascular fat, and that's a therapeutic target. So these are two different areas of research that are both very exciting, and they run in parallel.
Excellent. And so there is a question in the audience whether AI will replace doctors, particularly for CT and CMR reporting. I guess the answer is yes, to a degree, but I think as a co-pilot, possibly. But my question to you is, general, go ahead.
I said for now.
For now, exactly. We still integrate a lot of clinical information. In my reports, in my MRI reports, I often look at ECG, sometimes, and I use that to make the final determination of what the MRI images suggest. So do you think now, a word of wisdom for the general cardiologist in the audience and all of us, so do you think AI should be included in the curriculum of the future cardiologists?
I think we have to, right? This has to be included in some form into the curriculum. I'm not talking about teaching clinicians how to train AI models, and I'm not talking about teaching clinicians how to set up AI analytics or networks, but in the interpretation and in the use of AI tools, I think this is something that has to happen. We have to get everybody familiar with these new technologies in order to use them in the best possible way. What I tend to say to my students is that the good doctor of the future will be the one who knows how to use AI. And it will not be the one who is replaced by the AI, because that would be a doctor. Okay. So that should be the approach that we should follow in the curriculum.
Thank you. Thank you so much for these words of wisdom. And I'm sure Filippo has more questions, and I'm mindful that I've been dominating the dialogue, so I'll pass it back to you.
Well, coming back to your insatiable curiosity, which comes up so clearly, and I'm sure is an inspiration for our younger colleagues listening to our conversation. Coming back to curiosity, I sense that one of your recent babies is photon counting. Somebody believes that photon counting will replace cardiac magnetic resonance. What are your views? What is the perspective here? Also, can you please summarize what is photon counting for the audience?
Yeah, that's a very inflammatory question, Filippo, especially in front of Chiara.
Yeah.
CEO of CMI.
I am a well-known provocateur.
Yeah, okay. I need to be very careful in how I answer this question. So just for those who don't know what photon counting CT is, in the classic CT, we have these scintillators that they collect the photons as they pass through the body. They create visible light, and essentially you detect the visible light in order to reconstruct the images and visualize the structure that you are trying to visualize. With photon counting CT, each photon hits onto the detector, which could be of different materials. So at the moment, the one that is in the clinical practice has cadmium telluride, but there is a silicon detector. There are other type of technologies that convert each photon into an electrical signal, which means that you have spatial resolution of this technology that comes to 0.12, 0.13 of the millimeter for in-plane resolution, with a slice thickness that's down to 0.2 of the millimeter. So this is essentially iPhone resolution, as I tend to say. You get these unbelievable pictures. Then you capture all the energies simultaneously, because each photon has its own energy as it passes through the body. And then you can visualize your images at different energies. And by doing that, you can perform from the same scan subtractions. You can, for example, remove calcium. So if you have a calcified structure, you can remove calcium by subtracting the high from the low energies, and this is done automatically. Or you can visualize the myocardium and the late enhancement from routine scans. You can visualize hypoperfusion of the myocardium from routine coronary CT angiograms by visualizing the myocardium at very low energies, which are not useful for the actual coronary artery interpretation. So all these are things that are happening now. Now, whether you replace MRI or not, that's not, I don't like the question, because MRI has very specific indications and they are different from the indications of the CT. There is some overlap, for example, late enhancement, something that now we can do that with photon counting CT very easily, with late iodine enhancement, for example. And you can do it in a single cardiac beat in the context of a coronary CT angiogram. You get a second low energy acquisition a few minutes after the angiogram, and then you get this late enhancement. But you can never get the tissue characterization, the depth of the tissue characterization that you get with MRI. So there's an overlap, but there are different modalities. Let's keep them as different. Is that good answer?
Brilliant answer. Let me involve Chiara. So Chiara, are you like St. Paul fulgurated on the way to Damascus by photon counting, or you stick to cardiac magnetic resonance?
Yeah, well, as a cardiologist, I guess I'm excited with both, because I think they are indeed complementary. I mean, the resolution of photon counting is incredible, as Haris mentioned, and I think that's fantastic. I think, there is a lot of hype on photon counting, I have to say. I think we need to wait for the studies that demonstrate that actually this super high resolution is actually clinically meaningful. I suspect that it might augment the performance of the maybe not so experienced physicians, reporting the CT. And so like a, super AI, it makes the scans very easy to report because you see very well. So I think we need to wait for the studies and understanding, the cost effectiveness, also the technique, because it's very, very expensive currently. And also the dose of radiation is actually quite high, and this is not something that gets discussed. I mean, they only show pictures that are very, very nice, but the dose of radiation sometimes is extremely, extremely high. And I think, when you think about radiating patients, young patients, multiple scans, I think it's something that we must take into consideration.
Thank you, Chiara. And let's come to the last question for Charalambos. Well, again, a provocative question. What is the future of risk stratification in cardiovascular medicine? Bioimaging, biomarkers, or both? Or just bioimaging?
I would say it's all of the above, captured by AI. So essentially, the way that risk stratification will be happening in the future will be by combining all available information for the patient. If the patient has imaging information, then this needs to be taken into account. You need to take into account the risk factor. You need to take into account any biomarkers, the Lp(a), the LDL, omics. If there is in the future a clinically applicable omic platform, then you can take into account the proteomic profile of the patient. And then by taking into account all of these different types of information, you can use AI prognostic models to get AUCs of 1. And I think we are not far from there already. So even with the images only, with the CT, the models that we have, the AI risk model that we used last a few months ago, gets an AUC to predict cardiac mortality, which is 0.85 on its own, just from the pictures. So that's something that by complementing this with biochemical information, genetic information, multi-omic information, we are not far from one, the absolute risk prediction.
Yeah, and this is really, I hope that your prediction will become true in a short time, because I don't think that we can be very happy with current risk stratification based on traditional risk factors, where the AUC is a bit more than 0.6, a bit more than tossing a coin. So really, the step from 0.6 to 0.9 or 1 will be a major development. And let's not forget that cardiovascular disease remains the killer number one. And I think that one of the reasons why it's still the killer number one is that our ability to predict is much less than ideal. So really, we need new developments in this regard. And I hope that you are a good prophet today in saying that in a short time, the AUC will be close to 1. Well, this was my last question. Chiara, do you have any last remark from you?
No, thank you so much, Haris, for everything you've been doing and really innovating and moving the field forward. I think all these in novo imaging biomarkers, precision medicine via imaging and via omics, I think is really the future of cardiovascular diseases, Filippo mentioned as well. So I really enjoyed this dialogue and learn a lot about your journey, and I'm inspired more than ever to continue to work in this field as well.
Thank you.
Thank you very much, Charalambos. Thank you, Chiara. It's been really a fascinating conversation. I'm sure that your enthusiasm is contagious and will be really important for all of us, but for our younger colleagues in particular. Thank you very much. It's been a brilliant, interesting hour. Next dialogue will be on June 26th, the last Thursday, at 5 o'clock Central European Time. And next dialogue will be a special dialogue with 3 protagonists of cardiovascular medicine. I'm sure you will enjoy it. But for today, thank you again, both of you. It's been really a wonderful hour. We expect that between 2,000 and 3,000 colleagues will watch this dialogue in the next few days, next few weeks. I remind you that it is posted in YouTube and also in X. Thank you very much, and we'll stay in touch. Bye-bye.
Thank you. Bye-bye.